the second guest of honor. It's with great pleasure I take this opportunity to introduce Professor Stephen Eckenbach. He's joining virtually with us today from Germany. And Professor Stephen Eckenbach graduated from Friedrich Alexander University Medical School, Erlangen-Nürnberg, Germany in 1993, and subsequently completed his training in internal medicine and cardiology at the Associated University Hospital. Then he became a research fellow at the Department of Radiology and Cardiology Division, Massachusetts General Hospital in the years 2002 and 2003. He is the chairman of the Department of Cardiology and professor of medicine at the University of Erlangen, Germany since 2012. His main clinical interests are interventional cardiology, general cardiology, and cardiac imaging. Professor Eckenbach had won many academic awards, including Jan Board Award for Clinical Research of the Medical School of Hanover, Germany, the St. Thomas C. Cesario Distinguished Visiting Professorship Award from the University of California, Irvine School of Medicine, the Simon Dack Award from the American College of Cardiology, the Gold Medal of the Society of Cardiovascular Computed Tomography, Sir Godfrey Hounsfield Award of the British Institute of Radiology, the Pioneer Award of Cardiovascular Computed Tomography from the Society of Cardiovascular Computed Tomography, and the Fritz Ocker Award of German Society of Cardiology. He was the founding president of the Society of Cardiovascular Computed Tomography and has been the editor-in-chief of the Journal of Cardiovascular Computed Tomography. Professor Stephen Eckenbach is the president of the European Society of Cardiology for the mandate 2020 to 2022. So it is a great honor and privilege to have him as a guest of honor. And let me now invite Professor Stephen Eckenbach to deliver his talk on highlights from the hotline trials from the European Society of Cardiology Congress 2021. Over to you, Professor Eckenbach.
Thank you very much. It's a pleasure to be with you, albeit virtually and not in person. I very much regret that I cannot actually come to this Congress. And maybe you can allow me to share my screen, then I can actually show some slides, because you've given me the honor of speaking to you at this inaugural session of your wonderful meeting about the hotline trials, or some of the hotline trials that were presented at the ESC meeting, the European Society of Cardiology Congress in 2021, which took place end of August. At the same time, of course, this is another opportunity for me to welcome you as an affiliated cardiac society to the European Society of Cardiology. We're very happy for the closer collaboration that we will have with your college in the future. But let me turn to the highlights from the ESC Congress 2021. Out of the many, many hotline trials that were presented, I have chosen a few to speak about this morning. And the first one is the EAMI trial. That was a trial that looked at influenza vaccination in patients with acute myocardial infarction. The background is that we know that there's a relationship between influenza infections and acute myocardial infarctions. And in the weeks after an influenza infection, we know that the risk to have a myocardial infarction is about 5 to 6 times higher than in the general population. So infectious disease triggers myocardial infarction. And I'm sure that in the future, we will see a lot of data also around the COVID-19 pandemic. But in this case, we're talking about influenza and how patients after influenza infection, as any other severe infectious disease, probably because of increased plaque vulnerability, have a higher risk of myocardial infarction. So in this context, the EAMI trial was presented. It was a trial that was coordinated in Sweden, but it was a worldwide trial in 8 countries, from Denmark to Australia. And in a total of 30 hospitals, patients who had an acute coronary syndrome, either STEMI or non-STEMI, in a very, very small percentage of patients with severe 3 vessel disease, but 99% of the patients had an acute myocardial infarction. So in 30 hospitals in 8 countries, these patients were randomized to receive in the influenza season either placebo or influenza vaccination in the hospital stay within 72 hours of the acute coronary syndrome. So not just a recommendation to undergo influenza vaccination, but actual influenza vaccination in the hospital. You can see that the mean age of the patients was about 60 years. The majority were male. And as I said, 99% had either STEMI, 53% of the patients, or non-STEMI, 46% of the patients. The trial was supposed to be even larger, but it had to be stopped prematurely due to the overwhelming influence of the COVID-19 pandemic. So it was stopped after including 2,571 individuals. And here is the primary endpoint. It was a primary endpoint of all-cause death, myocardial infarction, and stent thrombosis in a period of 12 months after the event, so either vaccination or placebo. And you can see a significant and large difference between the event rates in the placebo group and in the vaccinated group. The combined event of all-cause death, myocardial infarction, and stent thrombosis. And here is the curves for the secondary endpoints, the individual components of the combined endpoint. So you can see that there was a significant and strong reduction of all-cause death. There was a significant and strong reduction of cardiovascular death. And the worry that in fact that the immunization might cause stent thrombosis was not founded, because there was no difference in myocardial infarction between the vaccine and the placebo group, because that was the worry that you might protect patients from infection, from having influenza and subsequent events. On the other hand, the worry that the influenza vaccination itself might predispose to stent thrombosis, but that was not seen. So an impressive and significant result. 40% reduction of all-cause death, 40% reduction of cardiovascular death by influenza vaccination during the hospital stay in patients who were admitted with acute coronary syndromes in the influenza season in this very large global study. What is a bit unclear is how was cardiovascular death reduced when myocardial infarction was not reduced. So this is one trial question that remains around here. What were these cardiovascular deaths that were so significantly reduced when there was no reduction in myocardial infarction? Nevertheless, the authors concluded, and this was a widely seen and respected trial among the ESC presented hotline trials, that the opportunity to influenza vaccinate patients during the hospital stay for acute coronary syndromes is a very interesting one. It does reduce the risk of all-cause death, MI, and stent thrombosis. It also reduces the individual components of mortality and of cardiovascular mortality, and it was well tolerated and safe. A new concept to vaccinate patients right in the hospital. Another large and impressive trial was the SALT and coronary events trial, SALT and atherosclerotic events trial, the SALT reduction study performed on a very, very large scale in China and simultaneously published in the New England Journal of Medicine. This last trial had 21,000 participants across 600 villages in China. It was not the individual participants who were randomized, but it was the villages who were randomized, and in each village, approximately 30 participants took place. In order to be included in the trial, the participants would have to have a high stroke risk. Their age needed to be at least 60 years, and either do they have to have prior stroke or uncontrolled hypertension. So individuals with a high stroke risk. Most of them, you will see later, had a prior stroke. Now, these individuals were randomized to an intervention of either replacing the normal salt by a mixture of 25% potassium chloride and 75% sodium chloride. You cannot replace the entire salt because it would taste differently. So the salt substitute contained 25% of potassium chloride, and the intervention was to either use normal salt or this salt substitute, in which 25% of the sodium chloride was replaced by potassium chloride. If you would replace more, it would start to taste bitter. The patients were followed up for 5 years. Once again, these were patients with really, really exceptionally high stroke risk. That has to be kept in mind when looking at this trial. The mean age was 65, 72% had a history of prior stroke, and 88% had hypertension. The mean blood pressure was 154 millimeters of mercury, even though 80% of the participants were using at least one blood pressure lowering medication. So really high risk patient that needs to be kept in mind. However, the results were impressive. By this purely dietary intervention, replacing a bit of sodium chloride by potassium chloride, the stroke risk was reduced by 15%. In absolute numbers, the stroke risk rate went down from 3.4 to 2.9%. The overall MACE risk of major adverse cardiovascular events was reduced by 14%, and death was reduced by 12% relative risk reduction. The absolute risk reduction was from 4.5% to 3.9%. So impressive relative risk reductions, small but significant absolute risk reductions, number needed to treat, approximately 200 over a period of 5 years to reduce one event. How is this comparable? How is the diet in China compared to the overall global diet? The mean salt intake of these individuals was about 11 grams per day, most of which was taken in through discretionary salt, so salt added during cooking or during eating. As we all know, the recommended WHO intake for salt is 5 grams per day. If you look at Sri Lanka, I found some information from a national salt reduction strategy that was recently published. At the moment in Sri Lanka, there's assumption that the average salt intake per day is 10.5 grams per day. Again, most of it, like in this trial, through discretionary salt. So the results seen in this study in China, as far as salt amount intake is concerned, probably also can be transferred to the situation in Sri Lanka. However, your salt reduction strategy emphasizes that at the moment the salt consumption is 10.5 grams per day on average, but a substantial increase is expected because of the increased use of processed food. And we all know that processed food contains a lot of salt. So this is something to really, really look out for on a public health scale. Of course, the worst thing that individuals can do is consume fast food. Fast food contains a tremendous amount of salt. The meal, if you want to call this a meal, that you see in this picture, French fries, Big Mac, and a milkshake, contains 4 grams of salt, just this one single meal alone. So fast food is really detrimental to salt intake in the population. But looking back at this 4S, at the SSAS trial, the sodium reduction trial, once again emphasizing that the results are impressive with a significant reduction of stroke and overall mortality through salt substitution. But again, we have to keep in mind that this does not apply to the general population. These were selected extremely high-risk individuals. The majority of them had a prior stroke, uncontrolled hypertension, average blood pressure 154 millimeters of mercury. We have to keep in mind that these individuals took most of their salt in through discretionary salt and not so much by processed food. So the intervention gave them a lot of salt substitute. And the authors also emphasize that in this trial, sodium chloride was replaced by potassium chloride. So what we potentially see is also an effect of increased potassium intake and not just a reduction of sodium intake. This, of course, can not be clarified based on the results of this trial. Nevertheless, impressive what can be achieved by salt reduction. Another trial, and I will only touch this briefly because I know, or I would assume that we'll talk about this a lot more in the context of your annual meeting, is the Emperor Preserved trial. Again, published simultaneously in the New England Journal of Medicine, empagliflozin in heart failure with a preserved ejection fraction. An interesting trial presented by Stefan Anker because so far the notion was that in patients who have heart failure with preserved ejection fraction, there is no drug that is really useful to reduce events. Now, this trial included 6,000 patients. Clinically, there were heart failure patients NYHA 2 to NYHA 4, but ejection fraction was more than 40%. In addition, it was required to have elevated BNP levels to really prove the diagnosis of heart failure, but not reduced ejection fraction of more than 40%. Patients were randomized, in addition to their standard therapy, to empagliflozin, SGLT2 inhibitor, empagliflozin versus placebo, and then they were followed for a median of a bit more than 2 years. The outcome parameter was a combination of cardiovascular death or heart failure hospitalization, and the result was significant, a significant reduction in this combined endpoint. Mortality was not reduced, but the combined endpoint of death or heart failure hospitalization was reduced from 8.7% per year to 6.9% per year, a 21% relative risk reduction with empagliflozin in patients who had heart failure with ejection fraction of more than 40%. Lots of attention for this trial because it was the first trial in a group of patients with what we called HFpEF, heart failure without reduced ejection fraction. If you look at the data, you can see that there is a significant influence of what the ejection fraction really was. About 1/3 had an ejection fraction of less than 50%, and in this group, the trial result was highly positive. About 1/3 had between 50 and 60% ejection fraction, and in this group, the trial results were just about significant. And in those patients who had heart failure but an ejection fraction of more than 60% in this trial, again, another 1/3 of the patients, there was no significant benefit of empagliflozin. So it really seems to be the case that patients with HFpEF are not homogeneous. There are some who have a completely normal systolic function, and here the trial did not show any positive results. The positive results were limited to those in which the ejection fraction was somewhat reduced. This also needs to be kept in mind. So the HFpEF patients are probably a rather inhomogeneous cohort. After briefly mentioning Emperor Preserved, because I would assume that you will talk a lot about this in your Congress, one final trial that I would like to mention, also relatively briefly, an interesting concept, but also there was a lot of discussion around what this trial really means, so I would like to share this with you. APEF CRT. This was a trial in the difficult group of patients who have atrial fibrillation and heart failure, and we know that these are high-risk patients, high risk for repeated heart failure hospitalization and also high risk for mortality. Atrial fibrillation plus heart failure. This trial looked at the question whether there's a benefit of AV node ablation combined with cardiac resynchronization therapy in patients who have atrial fibrillation and heart failure. So the trial recruited what they called severely symptomatic patients with atrial fibrillation, duration at least 6 months, who were considered unsuitable for AF ablation or in which AF ablation had already failed at least once. The patients did not have a wide QRS complex, narrow QRS complex, and the patients had to have heart failure with at least one hospitalization for heart failure in the previous year. So severely symptomatic for atrial fibrillation, you can see later that the mean heart rate was 100 beats per minute, narrow QRS, and clinically relevant heart failure. 140 patients were randomized. 63 of them underwent CRT implantation, CRT, even though the QRS complex was narrow, CRT implantation. If the ejection fraction was reduced, additionally, ICD component was added. And 70% simply received rate control drugs to control the atrial fibrillation. You can see the mean age of the patient was 70, 56% were male. The heart rate on average was about 100 in both groups. The QRS was narrow, 95 and 94 milliseconds, and the mean ejection fraction was 41%. So there were some patients with preserved and some patients with reduced ejection fraction. Now, the results were impressive, or let's say at first sight, the results looked very impressive, where the mortality was significantly lower in patients who had ablation plus CRT implantation as compared to patients who only had drug control of their heart rate. So ablation of the AV node plus implantation of CRT, and at first sight, there was a significant and strong mortality benefit of ablation plus CRT implantation. However, the trial was extensively discussed. First of all, it seems to apply to only a very, very small group of patients, because across all the centers that participated in the trial, it took more than 7 years to recruit 140 patients. So this means that the patients were really heavily selected. Also, there was some criticism that digoxin was used a lot for rate control. And we know that digoxin might have side effects and might have downsides, even as far as mortality is concerned. In heart failure, not completely clear, but some question marks were raised here. And the most important point is that at the end of the trial, there were very, very few patients left in the trial. You can see here where the patients' curves diverged largely. There were only 21 patients remaining for 4 years or more in the trial. So this is really based on a very, very small number of patients. So we have to consider these trial results as interesting, but somewhat preliminary, based on the fact that there are relatively small patient numbers. And this is what was heavily discussed around this trial. So this was a quick look at some of the hotline trials that were presented: IAMI, the salt substitution trial, Emperor Preserved, and IPAF CRT. I hope it was interesting for you. This was a look at ESC Congress 2021, which took place completely digitally this year. Next year, we're going to Amsterdam. We're very confident that we can meet again in person in Amsterdam. Next year, we're going to Barcelona. Barcelona on-site and online simultaneously. The dates are August 26 to 29, and it would be wonderful if you could welcome some participants from your college also in Barcelona. I would very much look forward to seeing you there. Thank you much for having me as part of the inaugural session. Thank you very much for having the ESC as part of your scientific meeting. And as I said, I hope to see many of you soon in the future.
For the very enlightening lecture on the clinical trials that we saw in the previous ESC Congress. Thank you very much, and thank you for taking the time as well. I think given the time difference, I think it's probably quite early in the day for you, so I hope you have a pleasant day and a good Sunday, and enjoy your Sunday. The next item on the agenda, and it's a very, very important point in our inauguration ceremony, and that is to introduce the chief guest to deliver his address. And may I again introduce the President of the Sri Lanka College of Cardiology, Dr. Aniddu Pathirana, to introduce the chief guest today.
It's a great pleasure and privilege to introduce